2021. Thank you. To open the conference, I would like to introduce Dr. Julia Abelson, who is the Director of the Health Policy Program here at McMaster.
Thanks, Tamika. Hi, everyone. Really be with you to make some very brief opening remarks. I know you want to get on to the content of the conference. So I just wanted to first extend a very warm welcome to all of you on behalf of the faculty, the staff, and the students in the Health Policy Program. So welcome to McMaster and to this year's New Frontiers in Health Policy Conference. By way of background, just a couple of things to note. The conference was established, I think it's almost 10 years ago now, by students in the program who are keen to provide a forum for health policy oriented discussion, debate, for graduate students to share their work in a constructive and collegial environment, and also to network with each other around common interests related to the field of health policy. And I'm always excited each year when the conference organizing committee gets started, because they typically identify a theme for the conference that attempts to reflect some aspect of the current policy landscape. And so I want to congratulate this year's conference organizing team on coming up with quite a novel and I guess I would say another theme, really catchy title, Building a Better Normal, Innovation for Equitable Post-Pandemic Health Policy. And also just to pause to say a big thank you and congratulations to our conference co-chairs, Tatiana Villacrest and Tamika Jarvis, and the entire conference organizing team for the many hours of work that you to organizing this year's conference. I know not sure I'll have a chance to do that at any other point, so wanted to do it now at the beginning. And just to finally say that a particular strength that we see in this conference and of the health policy PhD program more broadly is its focus on trying to tackle really important pressing policy issues through an interdisciplinary lens, through interdisciplinary scholarship. So you'll see in terms of the structure of the conference over the coming weeks is a focus on different disciplinary areas. So political science starting off this week, a session on health economics and health systems and society. So the idea is to kind of think about these very tough policy problems that we're grappling with through single interdisciplinary lenses, and then capping it off at the end with what looks like a really exciting interdisciplinary panel later this month. So just want to wish you all a great conference. I know that there are, at last count, some participants, I think, from about 14 countries, which is really exciting. The virtual format allows that, which is a really nice new element to the conference. And so wish all of you lots of productive, stimulating, and fun discussions over the coming weeks. Back over to you, Tamika.
Thank you so much, Julia. So we'd like to begin the conference by delivering a land acknowledgement. So we begin by delivering a land acknowledgement that McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. So good morning, everyone, and welcome to New Frontiers Health Policy 2021. We are so happy to be hosting this conference again this year, Building a Better Normal. And while we have adapted to life during a pandemic, I'm sure that many of us are very eager to return to normal. We have been privileged to witness, and for many of us, participate in research about the impacts of the COVID pandemic, and also think about, forward-looking lessons about the future after COVID. So we host this conference as an opportunity for graduate students to share their research, including their works in progress in health policy and related areas. And so for this year's conference, it's planned as a weekly seminar of discussion grouped by our program's mainstreams, that is the political sciences, now health systems and society and health economics, with virtual oral presentations, as well as a discussion led by our faculty members from the Health Policy Program here at McMaster. And then finally, we'll close off with a really exciting invited expert panel on the theme, Rebuilding the Plane While We Fly. So looking at innovation within existing policy structures. So with that said, we welcome our first session. Today, we have 3 great presentations from Zai-Chun Zhao, Harman Sandhu, and Gurveer Dutt, followed by a moderated discussion and question and answer session with Dr. Andrew Costa, who is a member of the Health Policy Program. So we will begin, and just as a friendly reminder, please remember that to check that your microphones are muted and videos are turned off during presentations. And if you have some questions during presentations, please enter them into the chat. We will be using Otter AI for live transcriptions. And so to access transcriptions, you can click the link or the red button at the top left-hand corner of your Zoom window, or at the bottom of your Zoom window, you can click the live transcript button. Okay, and so with that said, we would like to welcome our first presenter, Zai-Chun Zhao.
Thank you, Tamika. Hi, everyone. My name is Zai-Chun Zhao. I'm a third-year PhD student in economics at McMaster University. And my presentation today is about my paper, well, the minimum wage of Canada's supplementary health insurance. We know, although increasing the minimum wage is the most common tools that policymakers can use to increase the incomes of the low-skilled workers, it also brings some negative impact on the job market, and particularly on the new graduates and the low-skilled workers. And I found the literature is not conclusive. Someone found this increasing minimum wage will bring a negative impact. Someone found there's a positive effect, or someone just found there's no significant impact on the job market. And some people want to explain this situation by the fringe benefits, because instead of just firing some people, employer can cut off some fringe benefits, such as the sick leave, paid vacation, job training, and the most expensive part, the health insurance. So most of the current research is based on the United States, where an employer can provide basic health insurance for employee, and they can reduce those health insurance to offset this increasing cost. And Carl and Kruger both focused on the fast food industry, and they found there's no significant impact on the providing of the health insurance from the employer. But Royalty 2000 found if the increasing minimum wage will bring a significant negative impact on the low-skilled workers. But the situation in Canada is different. Like we have several public health insurance policy, like the OHIP in Ontario, covered almost all necessary treatment for people. So people can go to the hospital or the working clinic without incurring large expenses. But those public insurance programs do not cover prescription drugs, eye checks, dental service, long-term care, and the private hospital insurance. If people want to buy those insurance, people can only get those insurance by their employer, the union, or just buy some private insurance. So based on my search, there's no paper studied the effect of the raising minimum wage on the provision of the supplementary health insurance by employer in Canada. So my paper will be the first one to analyze this relationship in Canada. And almost all current papers only analyze the availability of the health insurance, which means you have or you have nothing. But employers can renegotiate with the employee about the generosity of the package, which means employer can cut some insurance service in the package, but keep other things. So I would examine this relationship between the components of the supplementary health insurance, just like I mentioned before, prescription drugs, vision, dental, and others. The data I used is from the CCHS data set from 2009 and 2018, 10 provinces, and by using a difference model to analyze this effect. And from data I found for each year, each province, around 9 to 8% workers are affected by the new minimum wage policy. So I grouped all workers by their income level, 0 to 10, 10 to 50, 50 to 90, and 90 to 100%. And in each group, I separate them into the full-time job workers and part-time job workers to find a specific effect. In my difference model, there are 5 key outcome variables. The first 4 are the elements of this supplementary health insurance. Whether an individual has a prescription drugs covered by his employer, or whether he has a dental insurance, vision insurance, or other insurance covered by his employer. And the last one is the supplementary health insurance itself. For example, if I only have the dental insurance, but no other insurance covered by my employer, I will be treated as I have this supplementary health insurance in my model. And for the right-hand side of my model, the key explanatory variable is the real minimum wage in province P in the last period. Well, the reason I choose this one period lagging model is that even though some employer want to change their insurance policy, they need to the new insurance policy will take effect in the next year, since you already pay for the insurance premium for the whole year. And for the third one, the year T captures the time trend, and the sigma P denotes the province fixed effect. And in the vector X, I include some individual characteristics such as age, sex, race, education level, and others. So let's go to my main result for the table 1. For the 0 to 10% wage income level wage earners, we can see for all workers in this group, this recent minimum wage brings a negative impact on the prescription drug insurance. And for the part-time workers, this negative impact happens in the total supplementary health insurance, prescription drug insurance, and the dental insurance. And for the full-time job workers, there are almost no significant negative impact. And one interesting thing you may notice is that although this minimum wage increase every year, the workers tend to supply more dental insurance to their workers. And you can see for the full-time job workers, they have 16.2 probability to receive this dental insurance. Another information we can get from this table is there is a gender gap and a race gap around this job market. Like for the if you are male workers or you are white workers, you tend to have more probability to receive this supplementary health insurance. For my table 2, we focus on the 10 to 50% income level wage earners, and we can find there is some spillover effect happening in this group. For example, for the part-time workers, they tend to lose their vision insurance, and for the full-time workers, they tend to lose their prescription drug insurance. And also, we still find the gender gap and the risk gap in this income level group. And we go to the third group, 50 to 90% the spillover effect almost disappeared except for the part-time job workers tend to lose their prescription drugs insurance, but there's no effect on the full-time workers. And also you can see the risk gap almost disappeared, but there's still a gender gap. Like if you are male workers, you still has a higher probability to receive those supplementary health insurance. And for the richest people in my data site, we can see there's the negative impact from the raising minimum wage totally disappeared, and the gender gap and the risk gap almost disappeared. So let's go to my main result. So I found this raising minimum wage result in decline in the supplementary health insurance, especially for the part-time job workers, especially for the part-time low-wage earners, and they tend to lose their supplementary health insurance, prescription drug insurance, and the dental insurance. And also the spillover effects has been found in the 10 to 50% group, and the probability of receiving the version insurance for the part-time job workers decreased, and the probability of obtaining the prescription drug insurance for the full-time employees is decreased. And also in my model, I found the male and white workers have a higher chance of obtaining supplementary health insurance by the employer. So this is my presentation today. Thank you, everyone.
Thank you, Zai-chan. Okay, and next we will welcome our next presenter, Harman Sandhu. Harman, please feel free to begin when you're ready.
Sounds good, thank you. And so welcome everyone. My name is Harman and I'm a PhD student at the University of Toronto. And today I'm going to be presenting a comparative analysis of COVID-19 outcomes and long-term care systems in Ontario, Canada, and Victoria, Australia. So just before I begin my presentation, I do want to acknowledge that the impact of COVID-19 in long-term care homes in Ontario has been devastating, and I've been privileged not to have been directly impacted by this crisis. So while I aim to be respectful in my presentation, if anything comes across as insensitive or offensive, I'd love to have a conversation and discussion about it following the presentation. So a bit of background, long-term care, or LTC, systems enable people to receive healthcare and social support, sometimes through LTC homes, which provide 24/7 support. COVID-19 had a disproportionate impact in LTC homes in Canada, and a lot of questions were raised around the effectiveness of the LTC system to begin with, especially in comparison to other countries such as Australia, which fared a lot better. So comparative long-term care system analyses are emerging and can help reveal insights for informing systems and policy change. So my objective was to systematically compare the LTC and COVID-19 contextual and system level factors that may have contributed to the different outcomes seen between Canada and Australia. So just a quick note about the comparators. There are a lot of similarities between Canada and Australia at the national level, and then Ontario and Victoria at the subnational level. Both are high income economies, federal parliamentary democracies, have large land masses and dispersed populations. Their overall health care systems are similar in the sense that they're national health insurance systems, and then LTC services are funded by the government through taxation. However, there are two key differences to note. In Canada, the provincial government, Ontario, for example, is primarily responsible for LTC. In Australia, it's the federal government that's primarily responsible for LTC. And so you'll see a sort of two levels of comparison occur throughout my analysis. The conceptual framework that I've adopted to guide my analysis is known as the controlled NOPS framework. And so the factors that I'm interested in comparing at the system control level include financing and payment, regulation, organization, behavior, and then COVID-19 policies, which I've supplemented into the analysis. And the outcome of interest here is related to COVID-19 outcomes that have occurred in LTC homes in both of those jurisdictions. And so data were obtained through a review of the gray and academic literature, and I've listed some of the sources from where I got the COVID-19 outcome data on this slide here. And so I'll guide you through initially the COVID-19 outcomes. So what I did is I looked at COVID-19 outbreaks, cases, and deaths in LTC homes and among LTC residents in Ontario and Victoria based on cumulative data. So what that means is like the total data as of March 28th, 2021. And what we see here on the graph on the left is that out of total LTC homes in both those jurisdictions, a larger proportion of homes in Ontario had experienced an outbreak than Victoria. And a similar pattern follows in the middle graph here. A higher proportion of residents in LTC homes in Ontario were infected by COVID-19 than Victoria. And then relatedly, in the last graph here on the right, more residents died because of COVID-19 in Ontario than Victoria. And in terms of the COVID-19 policies and the response that the government had, broadly, they are very similar between the two jurisdictions. So what you have is you have visitor restriction and COVID-19 screening that took place really early on. There's sort of funding that's being given to both systems to sort of support the COVID-19 response. One key distinction early on in Ontario is that Ontario had an emergency order to facilitate the redeployment of its workforce and new hiring. And that may have inadvertently actually led to staff working at multiple sites, which is not good for virus transmission because that might even facilitate it. And that was corrected a little later on during the pandemic. And then finally, another key sort of difference is that Ontario opted to send individual inspectors to LTC homes to sort of coordinate a response at the local level. And that eventually sort of developed into local infection and prevention control teams at the LTC home. In Victoria, what you saw is a more centralized establishment of a center, which sort of brought together different actors to coordinate a response and distribute resources at the state level. In terms of other system characteristics, the financing and payment between Victoria and Ontario are similar. You have the governments providing funding to LTC providers for various services. The budgets between the two jurisdictions are very comparable. And then you typically have the resident pay an accommodation fee or co-payment with some subsidies available for those who are low income. One key difference is that the co-payment range does differ. Ontario's range is a little bit higher than what someone in Victoria would have to pay. In terms of regulation, the similarities between the two are in terms of the legislation that they have for regulation. So you have the LongTerm Care's Home Act in Ontario, which is governing at the provincial level and provides standards of care. And you have a similar comparable legislation in Australia, which is the Aged Care Act, which comes along with a national set of standards, which is governing sort of nation or countrywide. A key difference in regulation to note is that in Ontario, there's a trend towards decline in monitoring of LTC homes and doing inspections. And the opposite trend is seen in Australia, where Australia has actually established an independent agency to monitor quality and safety. And they have been pretty active in issuing notices of non-compliance. Moving on to home ownership, this is sort of another interesting aspect of the organizations of the system. In terms of total homes, LTC homes in each jurisdiction, who owns them is very sort of similar across Ontario and Victoria. So what you see here is that the majority of ownership actors are private for-profit in both jurisdictions. And then public and government actors usually have a less proportion of homes that they own. And just continuing onto the organization of both systems, similarly, like I was saying with the legislation, in Ontario, you have the Ministry of Long-Term Care, which is providing the oversight and is the main actor and overseer of the LTC system. And then in Australia, the counterpart is the Department of Health. There are also advocacy programs and councils. They exist more at the local level in Ontario, and they exist at the national level in Australia. A couple of differences in terms of organization to note is that in Ontario, the entryway into an LTC home placement is facilitated through 14 local organizations. They were formerly known as LINs, whereas in Australia, it's a national program. And then some rough calculations shown here estimate that Ontario has a slightly higher number of employees per resident in LTC homes than Australia. And then finally, in terms of behavior, really just looking at sort of the norms or the societal and cultural factors here. Overall, there's an increasing demand for LTC in both jurisdictions and a demand for LTC homes. Sort of slight deviation or difference between the two jurisdictions is that in Ontario, the system's built on an institutional model that's focusing more on primarily on physical and medical care, whereas Australia sort of developed more to think about aged care more broadly, considering care in people's homes and communities. And so to summarize, Ontario experienced relatively more outbreaks, cases, and deaths in LTC homes than Victoria. And COVID-19 policies were similar between the two jurisdictions, save for two differences. One was that Ontario's initial redeployment strategy may have contributed to virus transmission as staff worked at multiple sites. And then secondly, Ontario had a decentralized coordinated response, whereas Victoria's was more centralized. In terms of system level factors, there were a lot of similarities. The one key difference was that Ontario's monitoring had decreased over the past few years, whereas Australia's sort of went in the opposite direction where they established an independent monitoring agency to boost regulatory compliance. And so the implications of this work, first, rather than providing answers, this analysis actually opens up more questions about COVID-19 and LTC systems. For example, should pandemic support and coordination from the governments be more centralized in nature, happening at the state or province level, or should they be more decentralized at the individual LTC home or public health department level, for example? Second, what is the role of monitoring and enforcement? Does more monitoring enforcement lead to safer LTC homes in the context of pandemics? And so those are some of the questions that I'm sort of left with following this analysis. And then finally, I learned last week that there is some new developments happening in Ontario following the Ontario Long-Term Care COVID-19 Commission's final report. A new bill has been introduced by the Minister of Long-Term Care, Rod Phillips, and there's a couple of sort of highlighted summary of the new things that are being proposed. And really, to me, it looks like a boosting of sort of the legislation Long-Term Care Homes Act as it were before. And then just a couple limitations I want to note. So the COVID-19 and data definitions reporting are slightly different from Ontario to Victoria. So a standardized comparison is difficult to make, and these results should be interpreted cautiously. Secondly, there are a lot of other factors that may have influenced the COVID-19 outcomes that were beyond the scope of this analysis. For example, the rate of community spread, individual infection prevention and control protocols might vary between different LTC homes. And then finally, the research team, which includes myself and Dr. Sarah Allen, reflect a very Ontario-centric point of view. And we don't have a balance of different perspectives and researchers from Victoria or Australia reflected in this analysis. So I just want to lastly end with acknowledging the comparative health systems and policy course at the University of Toronto that I took and had an opportunity to sort of plan and conduct this analysis through. And I thank you for listening and welcome any questions, comments, or feedback. Thank you.
Thank you very much, Harman. That was a great presentation. So next, let's call up our last presenter, Purper.
Just give me one moment, I'll bring up my slides.
Okay.
Can everyone see my slides?
Yep, looks good.
Okay. Well, thank you everyone for having me here today. And I will be talking about a scoping review that I conducted, which looked into the impacts of medical assistance and dying on nurses' emotional well-being. Nurses play an important role in providing MAID, and their presence is the most important predictor of how well a MAID death will go. However, participating in MAID can be emotionally distressing for nurses and can impact their emotional well-being. This emotional distress can affect the quality of care provided by nurses to MAID patients and dictates whether nurses are willing to participate in future MAID treatments. As a result, the impact that participating in MAID has on nurses' emotional well-being can reduce older patients' quality of care as well as their ability to access MAID. There's currently a lack of research focusing on how workplace policies and procedures impact nurses' emotional well-being. So for this review, workplace policies and procedures refer to those at the organizational and individual level, such as institutional policies, staff communication, support, and education. Determining the impacts of these policies and procedures is important in order to provide nurses with appropriate emotional supports, which may improve older patients' quality of care and access to MAID. The review's question was, what is the impact of workplace policies and procedures on the emotional well-being of nurses participating in MAID in Canada or the USA? The reason why the sample was restricted to Canada and the USA was just given the time constraints that I had conducting the review, and given that I was the only reviewer that was also conducting the review. The Sinal, Medline, and Joanna Briggs EVP databases were searched, and they were supplemented by hand-searching reference lists of the resulting journal articles. The search terms that were used are identified to the right of the slide and are organized by sample, phenomenon of interest, impact, and location. The search terms in each column were searched separately and then combined using the Boolean operator OR. The resulting searches of each column were combined using the Boolean operator AND. The searches were limited to journal articles written in English and published between 2001 and 2020. The resulting articles were then imported into Covenants and duplicates were removed. Articles were then screened according to their titles and abstracts based on the following criteria outlined below step 1. The articles that passed the title and abstract screening were subject to a full text review, and if they met the inclusion and exclusion criteria listed on this slide here, they proceeded to the data extraction phase. I will quickly go over the inclusion criteria just in the interest of time. Articles had to be from journals published in English between 2001 and 2020, include Canadian and American nurses data separately, focus on providing or counseling patients on MAID, and discuss how MAID-related workplace policies and procedures affect nurses' attitudes, experiences, and/or emotions. The following headings were used in the scoping review's data extraction matrix. So they are as follows: authors, year, location, aim and purpose, sample, design, policy, procedure, main findings, themes, and the quality that was assigned to each study that was reviewed. The first part of the analysis consisted of descriptively summarizing the studies that were reviewed, and these will be discussed later. Next, a simplified approach to thematic analysis was used to analyze and synthesize the findings. This consisted of first appraising and extracting relevant data from each identified article. Next, the main themes of each study were identified. These themes were then compared across all themes, and attention was paid to the workplace policy or procedure explored, and the resulting themes, the context of the studies, the sample characteristics, and the quality of studies. This process was repeated until the overarching conceptual themes were developed. In total, 208 studies were searched, 8 qualitative studies were reviewed, 5 were primary, and 3 were secondary. The total sample size was 133 nurses, with sample sizes ranging from 7 to 59 nurses in each study. The total samples consist of 80 to 90% females, but 3 of the studies didn't report gender. The age range across the studies was 25 to greater than 65 years, with 3 studies not reporting age, and 2 stating that participants were middle-aged. The sample was 85 to 100% Caucasian, but 3 studies did not report ethnicity. The overall sample consisted of nurse practitioners, registered nurses, and licensed practical nurses. All participants were either from Canada or the USA, and 3 studies were of low quality, whereas 5 were determined to be of medium quality. The following workplace policies and procedures were explored and have been listed on the slide here. So they were being pressured to participate in MAID, workplace policy forbidding MAID administration, implicit workplace policy of doing no harm, keeping silent about participating in MAID in areas where MAID was illegal, lack of clear legal, ethical, and professional MAID guidelines, inadequate education on how to provide MAID, inadequate support, and working with another healthcare provider when participating in MAID. Overall, 4 themes were identified. There were moral distress, uncertainty, fear, and emotional distress. Being pressured to participate resulted in moral distress because nurses who believed MAID was wrong were expected to do something that went against their moral values. Workplace policies forbidding MAID also led to moral distress. Nurses felt moral distress illegally providing MAID because it was the ethically but not the legally appropriate decision. Nurses also felt moral distress when unable to provide MAID because they were forced to witness a painful death. Likewise, implicit workplace policies of doing no harm resulted in moral distress for nurses because on one hand, they were expected to participate in MAID, and on the other hand, they were expected to do no harm. Lack of clear ethical, legal, and professional guidelines caused nurses to experience uncertainty about their MAID-related roles and responsibilities. This subsequently led to nurses feeling fear because they were unsure of what to do or what to say when participating in MAID. Nurses also felt fear after participating in MAID and as a result kept silent about their participation, especially in regions where MAID was illegal because of fear of professional or legal consequences. Nurses also felt fearful of participating in MAID given the inadequate education and support that was available for MAID providers. Working with another unknown healthcare provider caused nurses to feel emotional distress. For example, working with the physicians that the nurses didn't know well made it difficult to confront them in situations where physicians' actions were inappropriate. However, if this healthcare provider was known to nurses, this reduced the emotional distress associated with participating in MAID. This was in part due to the emotional support provided by healthcare providers to nurses. Finally, the lack of emotional support available to nurses involved with MAID resulted in increased emotional distress. This lack of support for nurses was emotionally draining and even resulted in further moral distress. Maintaining the emotional well-being of nurses is important as it can impact the accessibility of and the quality of care provided to older patients choosing to undergo MAID. The following practice implications and future directions aim to reduce the impact of MAID-related workplace policies and procedures on nurses' emotional well-being. To begin, providing guidance on how to respond to patients asking for MAID will help to reduce moral distress experienced by nurses providing MAID, especially where it is illegal. Moreover, providing clear MAID-related policies and procedures will reduce nurses' uncertainty by explicitly outlining nurses' roles and responsibilities. It will also reduce nurses' moral distress by providing clear policies on conscientious objection in situations where participating in MAID goes against nurses' moral compass. It will also help to reduce the fear associated with potentially doing something wrong while participating in MAID. Furthermore, providing appropriate emotional support will reduce the emotional distress experienced by nurses involved in MAID. This will also help reduce the fear and subsequent moral distress experienced due to a lack of emotional support. Having the necessary emotional support increases nurses' willingness to participate in MAID and therefore improves older patients' accessibility to MAID. Lastly, ensuring that nurses participate in MAID with another known healthcare provider will reduce the moral distress nurses experience and increase the amount of emotional support available when participating in MAID. Some future directions are that all the studies I've reviewed did not focus primarily on the impacts of MAID-related workplace policies and procedures on nurses' emotional well-being. Most of them focused on general attitudes, experiences, emotions towards MAID. Therefore, future research looking specifically into the impacts of MAID-related policies and procedures is needed. This research needs to employ a more representative sample, given that this review sample consisted of primarily Caucasian females. Future research needs to explore whether there are differences in how nurse practitioners, registered nurses, and licensed practical nurses are impacted, given that the different types of nurses hold different roles and responsibilities when it comes to participating in MAID. The scoping review had several limitations. First, only 3 databases were searched to identify articles relevant for the objective of this review. This may have limited the number of articles that were selected. If additional databases were searched, more articles may have been identified that were relevant to the topic of this review. Furthermore, I was the only reviewer, and as a result, if there were more reviewers available to help conduct the review, more databases could have been searched and more articles relevant to the review could have been identified. As well, having multiple reviewers could have also provided different perspectives when reviewing the data. Lastly, to help reduce the number of articles that needed to be screened and reviewed after the database's searches, articles were restricted to those that included nurses participating in MAID in either Canada or the USA. This excluded those nurses participating in MAID elsewhere and was another limitation of the scoping review. I have my references listed here, but I also welcome any questions, comments, or anything else you would like to discuss. And thank you for listening.
Fantastic. Thank you so much, Gravir. I would now like to invite Dr. Andrew Costa to facilitate our discussion and Q&A.
Thanks very much, Tamika. Thanks for the presenters, and thanks for inviting me to provide some hopefully interesting discussion points and questions that will lead into a much larger discussion amongst folks here. If you're able to, turn on your video. That way we can see each other's faces as we discuss. If you're not able to, no challenge, but I think that'd certainly be preferred. I think what I'll try and do is maybe start off with a couple of questions that I have off the top for each presenter in order, and then maybe lead into some thoughts around maybe a general discussion. And they're really kind of questions of mine to the group. But please, let's not let that be limiting of discussion. You know, I think hopefully folks can feel comfortable interrupting me as I maybe go through some comments, and we'll take it from there. So Zuchin, that was a really great presentation. And so my off the top question was around, help me conceptualize some of the let's call it net benefits for the low income cohort that you looked at around sort of a real dollar. Can you describe sort of a real dollar comparison around the benefits associated with that wage increase, and obviously the at the group level, the negatives associated with the wage increase to real dollar use of their benefits?
Yeah, yes, a very good question. Actually, I saw some papers to describe this this dollar value of this benefit. I haven't did any like those searching in my paper, but I will do it later.
That's great. That was my only thought there. Is really interesting analysis.
Yeah.
For Harman, this is an area I know a lot about, in fact, so I was really interested to hear about it. And but I won't sort of abuse my prerogative here. The framework you used was interesting. And as someone who's a lot more undisciplined in health policy areas, because I'm a health services epidemiologist, the NOB framework was sort of interesting. And I wondered around if you thought about some of the assumptions in the framework, or the let's say the utility of the framework in looking at some of your particular outcomes. I'll say two things. Number one, around maybe the dubious evidence around regulation being good in the sector. And number two, when you look at COVID outcomes, them being far and away substantially influenced by, as you said correctly, community infection rates, which of course are very different between Victoria and Ontario. What were your thoughts around selecting the framework? Yeah, just curious about that.
Excellent question. And so, right, this is a key thing to consider here is that a lot of the times with any sort of health system comparison, you're looking at an outcome, and we can even sort of, I think, extend this to determinants of health. So a lot of times what we do is we compare health system structures and using these frameworks like control knobs framework. But when we're looking at health status, like what really determines health? Is it in the explicit healthcare domain? Is it in social determinants, ecological determinants? And so certainly the problem at hand gets bigger and bigger the more you think about it. In terms of this specific comparison, so the control knobs framework, I think one of the assumptions I like about it is that it accepts that there are limitations to what the control knobs framework can do. And the reason why it's just focused on the health sector domain is that because the sort of knobs, so to say, are chosen as things that you can sort of turn, dial, and change within the health sector. So it understands it can't change everything, but it can maybe change a little bit of the health system that might have an impact down the road on the COVID-19 outcomes. COVID-19 for sure is chosen more so of a focusing event that shone a light on maybe the deeper issues at hand. That's not to say, you know, there weren't long-term care issues that could be identified beforehand. I'm sure you and other folks in the area have known about issues for a long time. But COVID-19 more so, I think, acts as a focusing event to take a deeper look. And so COVID-19 almost served as like a spur of looking at this topic a little bit deeper. But I think I'll end my thoughts there.
Yeah, that's great. And if I could tie together some themes here, it's the idea of kind of intentions and consequences around policy actions that are assumed to lead to consequences. And of course, I think what you touched on, and certainly what Zuchin touched on, was around a little bit around sometimes where they don't facilitate the outcomes you're looking at, or there is sort of adaptation and emergence problems that upset these frameworks. So generally, I'm interested in thoughts from the group around the utility of frameworks in these areas, and how you as students kind of value frameworks or maybe less value frameworks because of sometimes frameworks are really useful in conceptualizing ideas, but they also demonstrate sort of the inadequacy of many frameworks. Great. And then finally, Gavir, really great. Many of these topics couldn't come at a better time. And so congratulations to the committee for sort of collating this work, and you for doing it, all of you. Well-being is so important, incredibly important. I have no data to support it, but everybody I know in healthcare is essentially, and anywhere you look, they're suffering because of just absolutely staggering changes in their workforce because of changes in well-being, exacerbated by COVID, but a long-standing issue around essentially poor working conditions for healthcare workers across the board, generally, I'd say across the board, and well-being being very crucial. You touch on it in the context of MAID, which is a great context to look at, and it kind of, to me, demonstrates the kind of confusion had when policies come and decisions are made around what's acceptable, not acceptable in the clinical environment, and how it doesn't translate to that front line, and people are not supported. Common issue. You mentioned sort of the inadequacy of some of the information that you had gathered in your review. So I have a question for you. How would you, I'm sure you thought a lot about it, if you were to write a CIHR grant or another grant, how would you conduct an observational study on the question you're interested in? What would be some of the parameters that you would change?
I would look at more specifically on how the legislation surrounding MAID outlines what nurses' roles are, because that tended to be the biggest theme that I found with the scoping review, was that nurses, regardless if they were nurse practitioners, registered nurses, or LPNs, they didn't know what their explicit roles and responsibilities were. And these roles and responsibilities tended to change depending on the physician they worked in, for example, in Canada. And if the physician was overbearing, then nurses didn't do much. And then they felt moral distress associated with that because they felt they weren't providing the care that they were responsible for providing to the patient. Whereas on the other hand, they were expected to do more than they felt capable of. And this divide between what they were expected to do or what they were not expected to do, looking into how we could change the legislation so then it's more clear, would be one interesting aspect of it. Because during my literature search, I also found that when MAID was implemented, even physicians didn't know what they were expected to do. And as a result, research was put into that and outlined the roles and responsibilities of physicians, but I didn't find the same thing for nurses, especially since this is exactly what the nurses were mentioning, even in their separate settings that they were providing MAID. Looking into that would be, I think, something fruitful and important to help decrease some of the emotional distress associated with providing MAID.
Okay, and I'd be curious around sort of the role of sort of the regulatory colleges in some of this process, and but that's a good response. I won't delay because I know folks have their own questions. For me, the overall themes that I sort of see coming through is the theme of, and maybe I'm stretching it slightly to find a theme, workforce and health human resources. I'm not sure if others have sort of found that feeling. And I harkens back to a saying that I think I'm remembering correctly from Bob Evans, that the first rule of health economics, Julie, you'll correct me, is that every dollar of funding is essentially associated with a wage, and that healthcare is a human resource. To date, we don't have very good robots to provide health and human services to the population. And so I'm curious as to whether or not our frameworks and our focus give that enough credence, because I've heard that, and I could be incorrect here, is that for many up and coming health policy researchers, the human resource space is kind of generally undervalued as a space. And to me, I always found that interesting from someone who's more on the health services side, because it's everything. It's absolutely everything. So I'll leave that with you. Maybe you might comment on it or take us someplace else. And then, yeah, and I'm curious about how behaviors, particularly in the NOB framework, factor in, and where we see issues of sort of emergence and adaptation. And I've always kind of prescribed in my work into sort of a complex adaptive systems theory, which is sort of nihilist. It says like you can't really understand anything because it's always changing. And I like that actually. But I'm curious what folks think about that, because I'm seeing here, and maybe just because I've got a hammer and I'm seeing nails here, I see emergence around COVID and the fact that it's this really pernicious infectious disease that defies all probability, and it's an ultimate leveler. So there's differences between Victoria's system, our system, other systems. But to the extent that it's in the country, it kind of lays waste to any good system, any good idea. So that's an idea of emergence. And adaptation, of course, where wages are increased, but then employers adapt and reduce costs other places. And Zhichun, you did a great sort of discussion around how that can be balanced. So that's it for me. Thoughts on workforce, thoughts on frameworks and their utility in this space, and then questions for the really good presentations today. I would invite folks to jump in.
I'd like to start off. Thank you, Andrew, for sharing your thoughts. And again, thank you for all the presenters. I completely agree with Andrew that it looks like the next step in health policy, or like the next big hurdle, or one of the next big hurdles, is the workforce that we've really seen show up in all of these presentations. So I guess my question to actually, especially the healthcare workforce, as we continue to have a nurse shortage. And in long-term care, that's another issue. I think a trend I found throughout all the studies is that most of the studies were on Caucasian man or woman, like in the workforce. So we know from previous studies that people of color in long-term care homes, their work are particularly impacted by low wages or poor hours. And so I wonder if anybody in the research has found specific data on people of color working in the healthcare workforce, how that impacts them, and if there's any work being done to see if this, if the more, I guess, equalizing policies exist, or if that's something that we really need to work better on.
That's a great question. I can sort of like start off a little bit and then we can continue the conversation. I think that's a really important question, and sort of I didn't have I guess, time to really apply a diversity, equity, inclusion lens to this work, as I hope to do with everything I do. But in terms of like my analysis with long-term care systems, more so I've been following sort of the news on the side in Ontario, and personal support workers, for example, which are, I would say, like a significant aspect of the workforce in long-term care, did find themselves in a very precarious situation during the COVID-19 pandemic, especially as like the early sort of policies around redeployment, multiple staff working in multiple sites. And also, like, let me just note too, like I did sort of in my presentation, like I'm presenting it as a long-term care resident-centered analysis, but the definitions of outbreaks also include if a worker got infected with COVID-19. So even workers are reflected in this data. And I think in terms of the specific question around like the impact on like, let's say, populations that are underrepresented or marginalized in other ways, like people of color, I would say that's like a future direction to look into a little bit more. But it's definitely like something on my mind.
Even from my review, when I was screening articles that were searched using the databases, most of the participants tended to be Caucasian, and especially since I was looking at nurses, they also tended to be female. So even for my topic, it would be very important to diversify not only ethnicity as well as gender to see how different genders and ethnicities experience emotional well-being when providing MAID.
Just to say that was a great question to sort of lead off a discussion. You know, in my mind, I was seeing the same thing. I was thinking like, I'm picturing essentially the impact of rising wages in long-term care and what operators might do to change their the benefits that are already fairly meager to workers in that sector. And you know, these are mostly women with children who need those benefits, I should think, more so than older folks that might have, more likely to be new immigrants. And we see those in the data as well. And that's a challenge. And of course, that's a thread through. I think how are we supporting these folks in their workplace? They leave the role quite a bit. It's a very difficult, low-paying job, and largely in the senior sector across countries. To get to Harman's sort of comparative analysis, what you'll find is that we have this discrepancy of those that are vulnerable looking after those that are vulnerable. And then we wonder why we sort of have some of our terrible outcomes. And we have no slack in the system when we have these emergent issues.
Yeah, sorry, if I can jump in. And this is something that I was thinking about across, you know, this question about increasing wages, like as a motivator to attract people into the workforce, or like, for example, Premier Ford had just announced that minimum wage is going to increase to $15 beginning in December, or at the end of December. And so, and I was thinking about Zai-Chun's presentation about how in some of his analysis, there was like this trade-off between, part-time workers and full-time workers, and some of the supplementary health insurance offered. But then also, thinking to Gerger's presentation, where there's also a need to balance like the mental health and well-being of nurses who are witnessing like trauma. And so my thinking was around, where do we find this balance between compensating people, increasing wages, but also providing things like trauma-informed care or psychosocial care in the workplace. Yeah, sorry, my question, it was just around like, like this motivator, money as a motivator. I can't remember this like first year health econ concept, but money as a motivator over offering people things that benefit their own well-being.
And maybe to put a point on that as well, from what I've understood in let's say the long-term care sector, and I don't know, or maybe you're giving it too much focus, but it came up strongly, and I think is that oftentimes people will say, well, the lack of full-time work in that sector is associated with choice associated with higher wages and less benefits. And you wonder, is it a real choice? Certainly the immediacy of having a higher wage pays bills, but there's a consequence to not having benefits. This is a challenge. So then back to frameworks, maybe. If we were to sort of examine this challenge, what would be the appropriate frameworks, if not those established today? Go ahead, Julie, if you've got thoughts. Or
yeah, I wasn't actually going to answer that question, Andrew, but I was going to make a few reflective comments, one of which is around framework, so I will pick up on that. I think I just didn't get my hand up in time as you were posing your question. So one thing that I'm observing, which is really, not a surprise, I suppose, but worth maybe, mentioning is, despite this being the quote unquote political science session among, the other two are to come, you can see very quickly how you can't possibly talk about these issues without bringing in the others, right? The health economics, the social determinants, so it's almost impossible. And I was kind of curious when you set up the structure for this conference to think about how able would people be to stick within this one, disciplinary lens. So I think that's, maybe worth, thinking about. And I think it's great how you all have the capacity to do that, right? Because of you coming in with a little bit, you maybe have a particular area of specialization, but you certainly can cover the bases to some extent in the other areas as well. So that's great to see. I guess maybe just on the health human resource side, just for a moment, just to bring in another kind of level of complexity, is the idea of patients, family members, caregivers, and this increasing this label patient partners, caregiver partners as health human resources, right? So remember in the whole visitor issue, this notion that essential care partners weren't allowed to come in, and yet for many of these long-term care residents, a huge amount of the care for their loved ones was provided by the family members, right? And I know in some of the work I'm doing, this concept of patient partners and caregiver partners or advisors to the health system, even sometimes in very high kind of policy level discussions, is increasingly being, in the health system. And, on hiring committees within hospitals, on boards, a whole bunch of roles for patients and caregivers. And some of them see themselves as, resources to the health system. And therefore, if you get into a HR lens that you're bringing onto this, then you're adding another level, another kind of element to the workforce. It's also issues of compensation, right? Which I know have been big, right, in this field. So I won't go into that a lot of detail, but just to say there's another layer onto all this. And then back to the frameworks, to bring it back to your question, Andrew, I thought it was great, nicely provided that you set that out at the beginning to say, what's the utility of frameworks? I kind of like this idea of everything's just very random and, system theory, chaos, etc. I guess where I sit, and I'd be interested to hear where others, feel the utility or maybe the lack of utility is around frameworks, is it at least gives you a starting point to kind of unpack things and explain. Otherwise, it's so overwhelming, could just really throw your hands up. And certainly in teaching health policy, which I'm going to have to leave to do in the next few minutes, we talk about the utility of frameworks to just help you manage and even break down incredibly complicated systems and decisions, because we know policy processes are incredibly complicated, and there are many stages and levels and policy actors, et cetera. So the role of frameworks to at least help you unpack some really messy stuff that's going on. So it's very, not a particularly profound statement, but it certainly has been helpful to me when you attack some of this stuff. But you very quickly, and certainly in the case of all of the attempts to understand policies around COVID, very quickly see the kind of hitting a wall very quickly in terms of the ability for the frameworks that we have with us to be able to do the work, right, to move us forward. So definitely need to think about how do we build new frameworks, refine the existing ones, or other things entirely. So curious what people think about any of those comments. And I will probably leave in the minutes just to give people a heads up. Didn't mean to stop the discussion.
If I could just offer a quick comment on the frameworks, I do find it fascinating. As a student, I agree, I do appreciate, for example, comparative health systems analysis is a topic or approach that I was introduced to earlier this year. All right, so I'm still learning how to sort of grapple with this thinking, and starting off with nothing is very, very difficult, because my natural public health tendency is to go towards all of the determinants of health and start looking at everything. And at that point, it's just so hard to sort of manage all this information and make sense of it, especially if we're considering trends over time. Another, I think, complexity is that policy changes, especially when you're looking at topics that we covered today. There's a minimum wage change that's planned. There's a long-term care bill that was introduced last week when I was preparing the presentation. I would have been very embarrassed if I didn't even catch on to that, but thank God I Googled it last week. So I think in that sense, frameworks are a great starting point, and I like to think of them as a tool in the sense that if you have a job to do, you can maybe find a tool that will facilitate that job. You might be able to do a job without a tool, and then you might end up using the wrong tool and still somehow get a result from it. So the way I've sort of thought about frameworks is that they're there for our use. If we think they're appropriate, they might be helpful, but they shouldn't narrow down sort of our analysis. Because if I took, for example, a very strict approach to a framework use in my analysis, I may have not even thought about anything related to what the province or the federal sort of actors were doing around COVID-19 control, what sort of policies they had. Maybe I was just going to focus on whatever the framework said and stick with that. And so that's sort of my thoughts on framework. I would always prefer to learn about them and then sort of have the conversation about whether they're appropriate to use or not.
I would also say, although I don't have too much experience with health policy frameworks, I wonder if it would be important to take the advantages and benefits of different frameworks and combine them so that although using just one framework, you have one advantage as well as the disadvantages associated with one framework. Using multiple, you can combine them together into something that where you combine the advantages and look at a topic with multiple different views, which might help to point out different perspectives, issues and concerns, and different avenues to then direct future research as well.
I also sort of had a question I wanted to offer up as I was thinking about it as we talked about the trade-off between sort of complementary health insurance, wage increases, as well as Gurveer, your presentation around let's say supports, emotional supports for nurses. The one question I think a lot about when I'm looking at these sort of analyses is that if we identify a problem, who is responsible for it? If you talk about emotional support services, who is responsible? Is it the nurse in the individual? I think the individual view of health has been quite prominent in the past, but we're sort of, I think, broadening our perspectives on that as a sort of field of science. Or is it hospitals, or is it the government, right? The government, I think, is sort of the easy target that I think about. Like, you create legislation, you have departments that typically look over this stuff. Or is it service providers, right? Like, for example, in my case, in long-term care homes, is it the private for-profit incorporations who are responsible for sort of fixing any problems we're identifying? And I think that is a very sort of hard question to sit with, because in a system where you have maybe devolved accountability to multiple actors, it's hard to hold one entity responsible for anything. So I wonder if anyone had thoughts on, in our like view of our like sort of topics and health systems and healthcare, what are your thoughts about like who actually is responsible? Is it devolved? Is it central? Should we be looking to those entities to sort of help out? Like, how do we even go about solving some of these things that we found? I know that's loaded, but I'll leave it there.
That's a really great question. And I personally would say it should be more devolved, especially through my scoping review. What I was seeing and reading was that nurses, they would look for help from administrators, their regulatory agencies, as well as other nurses that they were working with, other healthcare providers. And that's why one of the main things was that if they didn't know the healthcare provider they were providing MAID with, this resulted in an increased emotional distress, moral distress, because they couldn't communicate with them or call them out when they were doing something that was inappropriate, or if they weren't supporting the families of the patients. So having a devolved view and putting responsibility on not just one centralized agency, but on multiple different entities, I feel like would be better, especially given that nurses in that context look for support, not just from one place, but from multiple different places. And I feel like peer support would be very important in that context as well.
I think I want to jump in there because that's really interesting, because I was thinking the other way completely, that it should be centralized, because one of the big issues in your presentation that you brought up is that there's uncertainty around the role of how nurses should participate in MAID. So if that were standardized, would there be better understanding of what their responsibilities are? Would that clear up some discomfort with the role? There's this conflict between do no harm and then the MAID. If we were to redefine the idea of do no harm on a systems level, like to the core belief of what nursing is, to include the fact that we want to ensure quality of life. If quality of life declines to a certain point, it's a nurse's responsibility to assist the patient in dying with dignity. Then would that also clarify some of the concerns that nurses have as well? So I think that's really interesting that we had different opinions on that. The question of centralization or decentralization of responsibility is something that I also was thinking about. And so it's a matter, and I was really wondering about that in your presentation, Harman, because Canada is significantly larger than Australia. And so like, I know it's decentralized as well, but like to what extent? Because Canada, we have federal and then provinces and then municipal and so on and so forth. I know Australia has provinces, but again, it's a lot, I'm assuming tighter knit. So I wonder if that affects how their COVID response was.
Yeah, the decentralization and centralization topic, I think like we should definitely open it up and talk more about it. So I'll let others chime in, but I'll offer a quick thought in terms of sort of my analysis. It's really hard to say in terms of like what I saw when I was looking at long-term care systems, because for example, in Ontario, it's a province, right, that's receiving sort of funding for other healthcare services that are being matched per capita basis from the federal government. So there's a bit of the Canada Healthcare Act, the Canada Health Act, I forget if it's CARES in there or not, but there's a sort of agreement there. Long-term care is a little sort of different in terms of Ontario taking the primary role in sort of collecting funds and then distributing them to LTC care providers who then provide the services. And I would say it's actually very similar to the way Australia does it. If one were to view Australia as a province, for example, and then you have different individual sort of regions. So in terms of like those two countries, I think they are actually quite similar. It's just where the level of governance happens is slightly different. And I think that has in turn opened up questions around, in Canada at least, there are, I think, the Health Standards Organization and the Canadian Medical Association right now are drafting sort of national standards for long-term care that they think should exist at the federal level. So there's always that question of, if you do have a higher level of government, can you look to them to provide support or guide anything? And maybe that's not possible in Australia because they are at the federal level. There's no other government. Maybe you can look downwards towards like the individual smaller state governments. But I'm curious to hear thoughts about centralization, decentralization more broadly, because that's definitely an interesting topic and important to sort of talk about.
I might invite folks to think about not just centralization and decentralization, because you live long enough, you'll see that it's fashionable, as well as it being a point of debate. And before COVID, delegations of folks were looking to Canada from Australia around how we regulate our long-term care system, believe it or not, because there are some of our good reporting systems. The decentralized aspect of some of long-term care saved a lot of homes where hospitals created collaborations between long-term care homes, breaking the rules. And think about potentially around not decentralization or centralization, but rather effective mechanisms to establish control in let's say, times of steady state and times of emergence as being kind of the most important thing. Like, for example, BC, where they basically took all the workers and made them provincial workers to stabilize the workforce. That was effective control, even though they have a decentralized system similar to ours here in Ontario. And then think of overshooting potentially, for instance, where it's the public probably thinks it's the case, but no one else I've encountered in long-term care environment, research, operations, or otherwise thinks that we need more regulation at all, because it's counterproductive. And in fact, the science table I sit on for current care, we're going to recommend that this needs to be under scrutiny because, there's more regulation in long-term care than there is in hospitals. And they're effective. They can't really use regulation very well because they are so marginalized. There's no back offices, or you have the alternate effect of creating big for-profit chains that can handle this regulation, right? Because they have back offices. Again, consequences, adaptation. So maybe think of effective mechanisms of control when you think about that. I'll leave it there. Thanks for inviting me. Hopefully I didn't abuse my privilege too much. It's really exciting to chat with everybody.
What a great set of presentations to kick off our conference. We'd like to thank our presenters for sharing their work and our discussant, Dr. Costa, for your insights and facilitating the session. So next Tuesday, November 9th, we'll be having our Health Systems and Society oral session, and health economics presentations will then be on November 16th, both at 11 a.m. Eastern Time. Registration for those sessions is still open. We'll also be hosting our panel session, Rebuilding the Plane While We Fly, Innovation Within Existing Policy Structures, on November 23rd at 1 p.m. Eastern Time. If you have any questions, please reach out to us at nfhp@mcmaster.ca. Thank you all and see you next week.
Thank you,
Thank
everyone.
you. Bye.